Are we live? Jay?
Yeah, we are live. You can start. Sorry for the delay.
Yeah, I'm so sorry to all the speakers over here for this mishap, and sorry for that. And we will start a meeting. So this is our disclaimer. The meeting is exclusively for the attendees, and if you are not inviting the meeting by Pfizer, we request you to please kindly log off. The meeting initiative reserves the right to block unattended recipients. Video or audio recording for this WebEx is strictly prohibited. So I will start with a brief introduction of all our speakers today. Today we have Dr. Sailesh Bondade sir, who is a MD fellow medical oncologist from Tata Memorial Hospital, and he is an expert in management of solid tumor, blood cancer, and pediatric cancer. Dr. Sailesh Bondade sir is an executive committee member of ICON, ISMPO, and also many other national oncology bodies. We also have Dr. Reshma Puranik ma'am with us today. Here, she's a DM medical oncologist and she's practicing in Kothruth, in Puranik Cancer Center, Kothruth. And also she's an assistant professor in DY Patil Hospital, Pune. Reshma ma'am has a vast experience and inimitable proficiency in managing diverse cancer segments. And also Reshma ma'am is a top ranker in institute in MBBS and MBBS and final MBBS. Thank you so much, ma'am, for being a faculty member for today's meeting. Also, today we have Dr. Vijay Sharnagat, sir. He's a consultant medical oncologist in Sunrise Oncology Center and Cardinal Gracious Memorial Hospital, Mumbai. His area of interest is in solid malignancies and hematology malignancies. And he also have publications on safety and efficacy in post-hematopoietic stem cell. And thank you, sir, for being a expert faculty member for today's meeting. We also have Dr. Shaunak Valame, sir. He is a consultant medical oncologist practicing in Jawaharlal Nehru Cancer Hospital and Research Center, Bhopal. Dr. Shaunak expertise lies in the management of lung cancer, breast cancer, and many other cancer segments. Dr. Shaunak sir has also presented his paper on stomach cancer at the Elite Gastrointestinal Cancer Symposium organized by American Society of Clinical Oncology at San Francisco in January 2020. And we also have Dr. Amol Kotalwar, sir. He is right now practicing in Yashodhara Super Specialty Hospital, Solapur, and he has interest in many cancer segments. He has done his hemato-oncology at prestigious Gujarat Cancer and Research Institute, Ahmedabad. We welcome you, sir. We welcome all the faculty members today, and now I will share my screen, and sir, Dr. Sailesh, sir, you can start the meeting, sir. Is my screen visible, sir?
Yes, it is. But I think, yeah, you go to the prior slides.
Yes.
Fine. So good evening, everybody, and thanks for the kind introduction on my behalf and also my colleagues who have joined this panel discussion on CDK4/6 inhibitors. And we know that from 2015 onwards, this group of molecules has changed the paradigm of treatment of metastatic breast cancers. I still remember the good old days around a couple of decades back when we used to treat metastatic breast. So irrespective of the reports, it was chemotherapy. And nowadays we can delay the chemotherapy for years together. And thanks to the hormone receptor positive metastatic breast cancers having CDK4/6 inhibitors as a treatment of choice. Next slide. That's the disclaimer. Next. So, as we all know that the ISMO guidelines, the NCCN guidelines, and advanced breast cancers treatment guidelines have approved CDK4/6 inhibitors as a category 1 treatment for metastatic recurrent non-operable stage 4 disease as a first line treatment. We also know that these are the drugs which can be used in second line post first line failures as well if the patient has not taken CDK4/6 inhibitors. Next slide. So these are the different studies which we know of, the Monarch, Mona Lisa, and the Palomas. We have been hearing these names for almost now 4 to 5 years. And we know the different CDK4/6 inhibitors, the three which are available, palbociclib, ribociclib, and abemaciclib. The studies with aromatase inhibitors as well as with fulvestrant in the first line and the second line, we can clearly make out that the hazard ratio favors that the CDK4/6 inhibitors in all the studies, randomized controlled trial for all the three CDK4/6 inhibitors. Next. So this is a diagram showing additional activity of abemaciclib specifically for CDK1 cyclin B more inhibition as compared to the ribociclib and palbociclib. Next one. So this is the data which has brought up a long-term overall survival as well as a long PFS for palbociclib. I think we all know that this is one of the first CDK4/6 inhibitors approved way back in 2015. So this was an update presented in ASCO 2022 of overall survival with the first line palbociclib plus letrozole versus placebo plus letrozole in a woman with ER positive, HER2 negative advanced breast cancers. Analysis from Paloma 2. Next. So as I said, this was the first CDK4/6 inhibitor which was approved way back in 2015. Now we also have a good experience of treating metastatic breast cancers with this particular molecule. Paloma 2 was the double-blind phase 3 study which demonstrated statistically significant and meaningful improvement in the primary endpoint of PFS, which was the confirmatory findings of Paloma 1. So after the median follow-up of 23 months, the PFS was 24.8 months with palbo-letro versus placebo letrozole of 14.5 months. At the time of presentation, the OS data was not mature. The final OS analysis was performed after the required events were reached with the median follow-up of 90 months. Next. So going back to the design of the study, this was a study for postmenopausal females with ER positive, HER2 negative advanced breast cancers with no prior treatment naive with ECOG of 0 to 2. They were randomized with 2:1 fashion, 2 for palbociclib and 1 for the placebo group. Palbociclib was started with 125 milligram per day and titrated as per the tolerance, 3 weeks on and 1 week off, the normal palbociclib regimen what we know of, plus letrozole 2.5 milligram per day versus placebo, equivalent placebo of 125 mg per day, 3 weeks on, 1 week off, plus letrozole. And the primary endpoint was investigator assessed PFS, overall survival, and the stratification factors was disease site including visceral and non-visceral, disease-free interval, de novo, metastatic, less than 12 months and more than 12 months, and prior neoadjuvant or hormonal therapy, yes or no. Next slide. Next. So if you look at the PFS, these are two graphs on the same slide. If you can make out, one is a lighter one and one is a darker one. The lighter one means the data cutoff was on February 16, and the darker one means the data cutoff was on May 31st, 2017. In both the graphs, you can make out that the PFS was significantly better when palbociclib was combined with letrozole versus placebo plus letrozole. The PFS was 24.8 months to 27.6 months in the two different time points versus the PFS of placebo plus letrozole of 14.5 months in both the graphs. Next. So these are the demographics of the study. You can see that the randomization is, remember the randomization is 2:1, so you can see more numbers on palbociclib and letrozole arm as compared to that of the placebo plus letrozole arm. Also, it's important to know that there are patients which were included who had a disease-free interval of less than 12 months from the end of adjuvant to recurrence. So what we call them as the endocrine resistant disease. So we have these patients included in this particular trial. Next. So if you see the intent to treat population, 666 patients were randomized into 2:1, 444 in palbos and letro arm, 222, that is 2:1 on placebo and letrozole. And you can clearly make out that the number of patients alive at the time of publication were more in palbo plus letro arm as compared to that of placebo plus letrozole, 25% versus 19%. But what is really alarming is the missing data. If you can see, the missing data was almost to the tune of 21% in the control arm versus 13% in the study arm. Next. Also, at the time of publication, you can make out that the patient who was still on treatment in the palbociclib plus letrozole arm were much more as compared to those of placebo plus letrozole arm. So, no, go back. So, what was the reason for missing survival data? The 66% were due to withdrawal of consent and 34 were lost to follow-up. This is something which is very alarming. Lost to follow-up is something which nobody wants in the clinical trial. We do clinical trials from last 15 years, and we really do take all the attempt to find out the survival data. The lost to follow-up means 3 successful attempts have been done, including a registered letter, but sometimes we go a little out of way to trace the patient and send someone to the house to find out what has happened to the patient. But what is important in a clinical trial is to get the survival data so that the study is complete. Next. So as per this study, if the data, if you look at the overall survival, both the arms are nearly superimposing on each other, and the HR ratio is 0.95. The OS with palbo plus letro is 53.9 months compared to placebo and letro 51.2 months. So why it is that there is no additional overall survival with palbociclib? Next. If you look at the subgroup analysis, it was very surprising that the patients who had a good ECOG had lost to follow. So this was really surprising. In fact, the patients who had a good ECOG, we expect the patients to come regularly for follow-up and take the treatment. But with the good ECOG performance status, we had a lot of disproportionate missing data in this particular study. Next. As compared to that, if you look at the patient with least disproportionate missing data are the patients with the poor ECOG and patients who had a prior endocrine therapy, prior chemotherapy, bone disease only. These were the patients where we had a least missing data. Probably, I think the patients who were to start with had a poor ECOG performance status improved, and then they probably felt that this is something which is really working, and we had a least missing data in this particular group. Next. So if you exclude those patients where we didn't have the survival data and re-look at the analysis, so what we call as a post-hoc analysis, after removing those patients where we don't have a good survival, we don't have a survival data, the median OS with the palbociclib plus letrozole was numerically better, though it was not statistically significant, but showing some idea, giving some idea that probably the missing data is something which is causing the OS to be not too good when compared to that of placebo plus letrozole. Next. So if there's another way of looking at it is if you remove the poor prognostic patients, that is the endocrine resistant patients who had a DFI of less than 12 months post completion of treatment, and take only patients with DFI of more than 12 months, you can clearly make out that the graph separates and you have a better, much better overall survival with palbociclib plus letrozole of 64 months compared to that of placebo plus letrozole of 44.6 months with a good HR of 0.736. So on the left hand side, you have all comers intent to treat population, and the right side you have a subgroup analysis where the DFI was more than 12 months, and you can clearly make out that probably in a hormone sensitive patients, the chances that you will get a good OS is much better as compared to that of hormone resistant disease. Next. So when you talk of OS, there are a lot of factors to be considered. It's not only the treatment and the effect of the treatment, but what patients takes after the treatment. So what we call is a post-progression treatment. Uh, so if you look at these patients who are followed up later, what are the different treatments taken by the patients? Next. And it is important to know that there were many patients, 27% of the patients from the placebo and letrozole group did receive CDK4/6 inhibitors later in the second line. And that is probably the reason why patient had a better overall survival in the placebo plus letrozole group, because CDK4/6 inhibitors was eventually given to these patients later. Next. The aim, as I said, the aim of the treatment, one of the aims of the treatment in using CDK4/6 inhibitors is to prolong the time to chemotherapy. We all know the quality of life with taking a tablet at home versus taking chemotherapy and having the toxicity, and to bear the toxicity of chemotherapy, CDK4/6 inhibitors is definitely better. So we try to delay the chemotherapy as much as possible. Now we have a lot of drugs which can be used in hormone positive patients, and chemotherapy can be delayed for quite a long time. And if you look at this data of Paloma, the treatment with palbociclib and letrozole, the time to chemotherapy was 38.1 months compared to placebo plus letrozole. So it does delay the time to chemotherapy in the lifespan of patients with metastatic HR positive, HER2 negative breast cancers. Next. The three studies which we always talk of, Paloma, Monarch, and Mona Lisa, also we discussed to start with a little bit about these names and the drugs which are used in this particular study. Paloma for palbociclib, abemaciclib for Monarch, and ribociclib for Mona Lisa. And you can clearly make out that the patient with less than 12 months of DFI were only included in Paloma. Only one patient was there in Mona Lisa, so you can practically say that this is the only CDK4/6 inhibitor which has at least some data to say that this, whether this can be used in the patients where there is expected hormone resistant. So it clearly says that even the patients with poor prognosis was included in this study. Next. So the same chart again put in a different way, the number of patients which were included. You can see that around 22% of patients with DFI of less than 12 months were there in Paloma 2, as compared to the others where most of the time it was excluded. The hormone sensitive group you can make out, and if you see more than 24 months, Mona Lisa is the one which has the maximum more than 24 months of DFI. So patients were selected the patients selected were really very hormone sensitive, and probably that is the reason, one of the reasons could be that you have got a better OS in this situation. Next. So now we come to some discussions and something which my colleagues will also talk about. So I'll request Dr. Reshma to take the first one. Whether do you think that the Paloma subgroup results are for patients with DFI of more than 12 months?
Good evening, sir.
Yes,
Sir, am I audible? I'm audible.
yes, you are. Yes, you are.
Okay. So, sir, the first question, the subgroup results with the patients of DFI more than 12 months. So, just like 2-3 slides prior, the graph which was shown by you, it clearly stated that the few subgroups, like especially this subgroup plus the bone-only disease and the PS1 to 2, and the one more subgroup. So, these were the ones in which the missing data was the least. So, these are the groups which actually did show a meaningful survival benefit. So one was this reason, and the second reason is being an endocrine sensitive group. So the subgroup results for these groups which did show the survival benefit. So I think it is convincing, and because the overall survival results have definitely been affected because of the missing data. But since these 4 subgroups, the missing data was the least. So I think the survival advantage which they showed, the months versus the months in the placebo group, the hazard ratio of 0.7, I guess that is significant. And we can take the benefit of palbociclib in this group definitely. And DFI more than 12 months, the endocrine sensitive group is definitely driving the OS benefit in the other trials also, like the slide prior which we just saw. These are trials which have this population in more percentages. So the survival benefit is also being seen. So this is how the results are also getting influenced. But we should focus on the subgroups actually.
That's great. Dr. Amol, your take on this?
Good evening, sir. I also agree with Dr. Reshma ma'am. Because of this endocrine sensitive group and patient which are having DFI less than 12 months, that is thing which are excluded in other trials and included in Paloma trial with these patients who are lost to follow are more. So that is driving the OS benefit in yeah.
I think Amol is traveling probably, so it's getting disconnected intermittently. Dr. Vijay, are you there?
Yeah. I'm there.
Yes.
See, the slides which you all showed, so they have said a lot of things. Regarding the first question, so subgroups analysis, where it was clearly like stating that with the subgroups which doesn't have any missed data, so they are showing benefit with the palbociclib along with letrozole, and where there is a lot of missed data, so they are favoring endocrine therapy like alone without CDK4 6 inhibitor. And where so second question, where the tumors when taken endocrine sensitive, so there is a lot of survival benefit when we actually exclude endocrine resistant cases. So this data is convincing to me.
Dr. Shaunak, suppose you have a patient with a DFI was less than 12 months, then probably without any thinking, you have the only one choice available. Is that so?
So that is a very interesting point that you made, that we've always looked at it in the other way, that because Mona Lisa and Monarch excluded the less than 12 month subgroup, that is why there is. But that point is true, that we only have data from Paloma that in an endocrine resistant population, that is the only kind of proof that we have. But considering real world analysis, that and the fact that all the hazard ratios of all the 3 trials are more or less similar, like HR of PFS is around 0.55, for OS it's about 0.75. So I think they are interchangeable in terms of where we wanted to respond, but there are certain populations where probably we'll prefer one over the other. But as far as data is concerned, less than 12 months, we only have Paloma.
Okay. Next slide, please. So again, Shonak, what you said, would you like to elaborate on the first line, whether you agree that this is the problem and that is the reason why
Yes, sir.
you don't have an overall survival issues, or there is also
Yes.
the other point, that most of the patient did cross over to take CDK4/6 inhibitors later as well. I think almost 27% of the patients did take CDK4/6 inhibitors in placebo control arm.
Yes, sir. But then crossover would have been there even in the Monarch and Mona Lisa trials. But I mean, one thing that stands out from the other trials is that this 20% definitely has made has a negative impact on the OS. But also that the time to chemotherapy is among the three trials highest in the Mona Lisa.
Dr. Reshma, in your clinical practice, how many percentage, just a rough estimate, that you see endocrine resistant population?
So the endocrine resistant population in my practice I see is not that much. Maybe 20%. So 80% of them are generally endocrine sensitive. So they have progressed after 12 months of adjuvant, or even if they are in the de novo metastatic group, they have progressed after the definition of primary and secondary endocrine disease. So more than 6 months. So the endocrine resistant population is definitely less.
Dr. Amol, your comment on this in your practice regarding the endocrine resistant progressing within on treatment or within a year of completion of endocrine therapy?
Yes, sir. In my practice also, sir, I am getting very less patient, around 15 to 20%, sir. Primary de novo endocrine resistant. All of my patients are usually, they are like sensitive to first endocrine therapy, and then they relapse after 1 to 2 years.
Okay. So actually, all of you are practicing in a metro. So I don't know whether there is a difference between a metro and a tier 2 city. But in my experience, actually, I am seeing quite a few. It's not so bad as almost 10% and 15%, but maybe around 40% of the patients are relapsing on treatment. Maybe they have a heavy burden tumors to start with, multiple node positive, maybe T4 disease. That also I think matters, other than just an estrogen receptors and other things. So, but of late, why I have picked up that there are more resistant cases, because I'm doing a study for metastatic breast ER positive, combining palbociclib and oral SERD. So I just noticed, it just came to my notice that it's not so rare to get endocrine resistant. Just one of the points which I wanted to make, because I have seen it in the recent, and I have noticed it actually. So Dr. Shaunak, Dr. Amol, your experience in endocrine resistant patients, do you put them on CDK4/6 or you start them on chemotherapy?
Sir, if burden is low and patient is not in visceral crisis, we used to start with endocrine therapy, and now there is an option of CDK4/6 inhibitor. So and it is a category 1 indication. So we now start with CDK4/6 plus this endocrine therapy.
Okay. Okay. Dr. Reshma, do you feel that this crisis, actually what we used to think of, that we should not put them on CDK4/6, has become we are becoming little more confident in using this, even in some liver mets and lung mets also, maybe some effusion also. And we are not so much afraid to put them on CDK4/6 as compared to what we used to, that any liver mets and things like that, put them on chemotherapy and not on CDK4/6.
Sir, actually, we have to consider the actual clinical profile of the patient. If it is few meds, and if the patient is not, maybe sometimes the patients are not even fit for chemotherapy, and overall tumor burden, if it is low, and if the patient preference, so there are a lot of factors. Even if we may consider a CDK4 inhibitor, like the cases like you just mentioned. But sir, if the patient is in florid crisis, I would rather counsel the patient for chemotherapy. If otherwise, the other population, it is fine. We can go for the CDK4 inhibitors.
Okay, so I think we are, as we learned a lot about the use of these drugs, we are becoming a little more confident in using this. even in something what we call as, I don't know whether we should use this term as a borderline crisis, but yes, next slide. So if you look at the endocrine resistant patients also, I think maybe this slide answers most of our questions, that even if there is a DFI was less than 12 months versus more than 12 months, the PFS is still there. We may not have OS with these patients, but at least we know that the PFS in these patients is better as compared to, and we have a reason to put these patients on this particular molecule as compared to others, because there's no data with the other molecules. Next. So as I think we did discuss in a couple of slides and also during our discussion, that loss of follow-up or missing survival data is something which poses a serious threat to the data of a clinical trial. And in the randomized control trial, it is suggested that anything more than 20% of loss to follow-up data, we have a serious issue in interpreting the trial. And in this study, we have seen that the placebo control arm had a 21% loss of survival data or missing survival data. So probably this is one of the reasons why we had the data which is not favoring the overall survival data which is not favoring palbociclib. Next. So, Dr. Vijay, can you take this? What impact of loss to follow-up data in both the treatments arm do you see an overall survival result? I think it's already written 13 versus 21%.
Yes.
And that is really, I think, which is
See,
hampering the results. Next one.
yeah.
Please go ahead.
Yeah.
Please go ahead.
See, if you see the randomization of this trial, so Palbase versus placebo, it is in 2:1 ratio. And
That's right.
see, in the placebo group, if this missing data is of 21%. So the large number of patients were missed when we compare this, because 2:1 means majority of the arm is in the placebo. And so there, the missing data is less, but in placebo arm, so it's only 2:1 means 1. So large number of patients were missed. So definitely, yeah, we are missing that thing.
Yeah, but I think one should make more attempts to really have a survival data. 21%
Yeah.
in almost 1/4 of the patients. If you don't have 21%, is as close as 25%. So 1/4 of the patients you don't have a survival data is really worrisome. Next.
Yes.
So is it the PFS or is it the OS that we always talk in all the conference, whether we want a PFS or OS? But I think this is something which guides us a little bit. This is an NCI Breast Cancer Steering Committee working group report, and you can see the 4 types of breast tumors. What we see: the triple negative breast cancers, the HR negative, HER2 positive, what we call triple positive, or and the one which we're talking about, HR positive and HER2 negative. So what is better? Is it an OS or is it a PFS? So here they have said that if the post progression survival expected is less than 12 months, then probably we should talk of an OS. And if the post progression survival is more than a year, then probably I think PFS is good enough, because there are a lot of other factors which will matter in the long term run of a patient. So if you have if you're expecting a low progression post progression survival, then it is an OS. And so for triple negative breast cancers, it is said that probably OS is a good marker to really plan the study and treatment. But as far as if you see the last column, the post progression survival is as to tune of almost 30 to 35 months. That's almost 3 years post progression. Then the PFS is probably what we should be looking for, and this is what the paper said. Next. So, Dr. Shaunak, will you take this? Considering the Paloma 2 data readouts and the limitations, do you consider OS as a class effect for all the CDK4/6 emitters? So, do you feel that if taken the same variables of the patient and you treat patients with either of the CDK4s, is it okay?
Yes, sir. It is a class effect. I think from the from real world, I mean, from my experience, I feel that what you said in that NCI data, that PFS is more important. I think what the patient sees is that what is the time to chemotherapy. So that is also being prolonged uh, as a class effect among all three, highest with ribociclib. So it is an option for all the patients who are not in visceral crisis.
Great. Next slide. So, adverse event, Dr. Vijay, how comfortable are you in using palbociclib as compared to the other CDK4/6 inhibitors, or you favor the other CDK4/6 inhibitors over palbociclib for some reason or the other?
Yeah, I usually favor palbociclib because when I started my practice, so this is the molecule which has came, so in 2015 onwards, and so this is the only molecule which was available at that time, and that's why see I have seen a lot of patients with this molecule only, and I do have a lot of experience with this molecule, and see it is tolerable, and many patients tolerate this molecule, and we have to monitor only CBC, and we have to see neutropenia, and sometimes we have to delay the initiation of next cycle because of the neutropenia. That's it. And I have never seen any patient with the infection because of the neutropenia. So incidence of febrile neutropenia almost zero to me. So I'm much more comfortable with the molecule, this molecule. The other molecules are there, but see, so they have come into the market later on and started using. But abemaciclib is the molecule which has come recently, means recently in just 2 years. And the adverse effect profile, if you see, so the patients, they are getting a lot of loose motions and it is continuously. So incidence of the thrombosis is also there. So which I have seen. I am much more comfortable with palbociclib according to my experience. Yeah.
Great. Of late, I think we all are forced into using this molecule, maybe because it is easily available now, and maybe more and more, basically more and more patients will get benefited with that. Dr. Amol, your take on this? I'm not discussing this toxicity profile. We all know that we have been using this molecule. Just an opinion,
Other CDK,
Dr. Amol.
yeah, yes, sir. Compared to other CDK,
Yep.
like ribo is having class effect of cardiac issues. So area with neutropenia. So compared to other CDK4/6, I will prefer this thing to give patient palbo because having very effect profile.
Okay, next slide. So to conclude about Paloma study, the Paloma 2 met its primary endpoint of PFS and other secondary endpoints. The overall response rate was 55.3% with Palbo plus Letro versus 44.4 with placebo and letrozole in patients with measurable disease. The safety profile we all know, and we are quite comfortable using this. Quality of life is something which is very important. So other than bone marrow suppressions, we have not seen other toxicity profile like what is seen in others like cardiac toxicity and diarrhea and things like that. So the quality of life is much better with palbociclib. Overall survival was numerically better in palbociclib plus letrozole versus the control arm, but the results were not statistically significant. Median survival over 50 months in this population represents significant improvement in natural history of HR breast cancers. Highlighted in the subgroup of patients with DFI of more than 12 months. I think we did discuss the overall survival is better with DFI of more than 12 months. and 10% of the patients are still continuing on the study after 7.5 years of follow-up. Next slide. So this is the real world data, and the real world data gives us an idea of other than the trial, whether this drug is really doing well. And this is a retrospective analysis. So the real world data needs to be taken with a pinch of salt. This is not a prospective study. This is a study which is taken from the database. It's a retrospective analysis of electronic health record using patient data from the Flatiron Health Analytic database. Over 3 million patient records were screened, 75% from the community practice and 25% from the academic centers. The examination, this was to examine the real world effectiveness of CDK4/6 palbociclib plus AI versus AI alone in the first line endocrine therapy in HR positive, HER2 negative metastatic breast cancers. Next. So you can see that this included the postmenopausal females and male aged more than 18 years with HR positive or HER2 negative. The starting date was from 3rd February 15 to 31st March 2020. So follow-up was from the index date to the death or study end, that is the data cutoff of 30th September 2020. 2 arms, palbociclib plus AI versus AI. How these figures came, I think we will go ahead and then discuss it. But the two terminologies which I want everyone to just have a look at is the written at the left side bottom. The statistical techniques to reduce the selection bias due to lack of patient randomization is the stabilized inverse probability of treatment weighing and propensity score matching. So SIPTW and PSM are the 2 words I think which are very important when you're looking at the real world data and how it is analyzed. The endpoints is overall survival and the real world PFS. Next. So what are the biases you can have in the real world data? This is not a randomized study. So these are the different types of biases you can get. You can get selection bias, reporting bias, misclassification, missing data, and confounding data. So how it is adjusted by using these 2 variables. Next. So what is IPTW and PSM? Basically, to be very short, IPTW creates a pseudo population, and PSM basically produces a pseudo randomization. So if you don't have adequate population to balance it, then IPTW is used, and when the randomization numbers are different, then PSM is used. Next slide will tell us in a better way. So here you can see propensity score matching means the population of varying characteristics are taken, and those who are not matched are not taken into the analysis. Those which are matched from the population are taken into the study group. Next. So IPTW means if you can look at the group A and group B, the comparator are much less. So it creates a pseudo population so that both the arms are balanced and it looks like a pseudo randomization. Next. So if you look at the 3 columns, the first one is the unadjusted cohort, while the others are after you have applied the SIPTW and PSM. You can clearly make out, for example, if you look at the patients with the age more than 75, you can see 23.6% versus 41.4% in 2 cohorts. If you look at after the IPTW and PSM are applied, they are almost balanced. So the standardization has to be less than 0.10 difference. Next slide, please. Again, here you have patients with metastatic breast cancers, de novo less than 1 year of DFI, 1 to 5 years, and more than 5 years. Next. So if you look at the graphs, the first one is showing an unadjusted analysis versus the two graphs where the cohort of IPTW and cohort of PSM are there. You can make out in all the three that the overall survival was showing an advantage of using palbociclib plus AI versus only AI, and you can clearly make out the hazard ratio of 0.6, 0.7, and 0.7 in the three graphs. So the OS was significantly longer among patients who received palbociclib plus AI versus AI before and after using the IPTW and PSM. Next. So the OS in the subgroups, you can make out that almost all of them favored palbociclib plus AI. I think brain metastasis is the only one, and in young patients premenopausal probably that favored AI only. Next. If you look at the PFS, the unadjusted analysis, and after the IPTW and PSM cohort were analyzed, you can clearly see that the PFS was better in all the three cohorts. The real world PFS was significantly longer among patients with palbociclib plus AI versus only AI. You can see that the hazard ratio of 0.68, 0.70, and 0.72 almost similar in all the three groups. Next. So what are the strengths of this study of Reality X? The large sample drawn from an extensive database records over more than 250. So it's a large database which is seen. The availability of a comparative control arm that allows a comparison of treatment similar to that of randomized control trial, and there's good follow-up time available. Next. What is the limitation? First of all, it is not a randomized study. Number two, like a clinical trial, all the assessments were as per physician's choice. There was no standard line or protocol for assessing the response to the treatment, like we use for CT scans, RECIST criteria and other things. So this was all depending on the principal investigator or the treating physician. We can't say principal investigator, but treating physician's choice. Next. So to conclude, the real world data, palbociclib plus AI was more effective than AI alone. The evidence support that the palbociclib in combination of AI is a standard of care in most of the first line treatment of patients with HR positive, HER2 negative MBC. Next. So another importance of real world data is something which is rare. So you cannot have a randomized study, randomized trial in that situation, like FDA approved palbociclib plus endocrine therapy in men with HR positive, HER2 negative MBC. So difficult to get a randomized trial in males with HR positive, HER2 negative disease. So data from the electronic health record was taken, post-marketing reports were taken, and that is how this approval was given in male patients with metastatic breast cancers. Next. So Reshma, considering the wealth of data across the RCT and the real world, do you think that there would be any change in treatment of practice among CDK4/6 inhibitors?
So now that we have discussed completely Paloma 2 final OS analysis and the real world data. So in the real world data, they have also used those two indicators of PSM and the other indicator, and which in the real world actually did show clinically significant benefit of PFS and OS. So considering both of these together, I think CDK4 inhibitors, palbociclib would continue to remain our choice in the metastatic hormone positive subgroup. And palbociclib, which CDK4 to use? is as per the comfort of the oncologist. But considering these two trials, palbociclib would definitely remain our choice in this subgroup, especially after we have heard about all this real world data. So would want to continue to, in spite of the OS data which has come up, want to still continue using palbociclib in the first line setting for the metastatic hormone positive group.
Dr. Shaunak, just it came to my mind. Someone recently was talking whether to start patients on 100 milligram and then to increase and then decrease. What is in your clinical practice? Actually, I have never done that. I always start with 125. But
I always start with 125, sir. I don't start at 100. I taper if required.
Because of late, when this generic palbociclib has come, there are a few companies which have come with 175. They have not come with 125. So I just heard someone saying, but this is something which was new to me. I never did to start with 100 and then see whether to increase or to decrease. It's always with 125 and then taper it down.
Yes,
So
sir.
this was new to me. So I stuck to my mind and I thought maybe we'll discuss. Dr. Vijay, in your practice also you use 125 and taper it down, or the start with 100 and go up or down?
No, usually I start with 125 milligram. But see, many of time now I come to know that. So ultimately I have to go to 100 because of the neutropenia, and sometimes I have to delay the next cycle maybe by more than 10 days. So in that situation, I'm tapering to 100, and now I can understand the patient's characteristics, who can tolerate 100 and who can 125. Then according to them, so that is like a experience only. So usually I start 100 milligram for the elderly patients who are more than 70. Usually, so I don't start with 125 milligram, usually 100 milligram. And according to their tolerance, I will see. I usually I step down, so I don't increase it to 125 milligram. So if it is 100, it is around 100 only. If they are not tolerating, then I will see. I will step it down to 75 milligram. But those patients who are younger, those who can tolerate 125 milligram, I start with 125 milligram only.
Dr. Amol, how frequently you call these patients for follow-up, specifically for CBC? Otherwise, I think most of the other parameters we do only if clinically indicated.
Sir, weekly we used to call them with come back with CBC for a first 2 cycles, and then afterwards we used to, if there is a neutropenia is not significant, then we can call them for 2 weekly or 3 weekly if patient is having no issues.
Okay. Next slide, please. I think we have already discussed this. Next. So coming to some Indian experience with palbociclib. Next. This is a real world data of palbociclib in metastatic breast cancer, obviously hormone receptor positive and HER2 negative. This is from Delhi. 188 patients with HR positive, HER2 negative patients on palbociclib plus AI inhibitors or palbociclib plus fulvestrant. So maybe first and the second line they're talking about. All premenopausal women which were treated had undergone an ovarian suppression or an ovarian ablation, either to make them postmenopausal. And these are the variables. Quite a good amount of patients with premenopausal, 57.5% premenopausal women, and 42% were postmenopausal. Next. The median PFS for first line were 20 months, 20.2 months. Second line median PFS were 12 months. Response rate was 80% for the first line and 47.9 for the second line. Toxicity profile as expected. Only 10% had grade 3-4 adverse event and 20% had grade 3 to 4 neutropenia. No patient had a febrile neutropenia. I think this is something what we see in clinical practice. Patient do get neutropenia, but hardly anyone has a febrile neutropenia, and the recovery is very good. I think rarely someone requires supplement of growth factors. So to conclude, the present real-world data of palbociclib used in Indian population suggests similar efficacy to previously published real-world data. Next. So this is another data from South India, palbociclib in HR positive real-world multi-center Indian experience from 5 centers from South India, giving us the real-world experience in India. 133 patients with HR positive, HER2 negative, receiving palbociclib. All these are single arm. Obviously, we are having a retrospective data capturing. So don't expect to have a randomized study. This is an experience sharing data. 83% were in the first line, 62% were in the first line and 37.6% in the second line. Median age was 56. The median PFS was still ongoing, so maybe we don't have a PFS. De novo metastatic versus relapsed, bony versus visceral. We can see that the de novo were obviously better. Bone only was obviously better. So we are yet to get the data from there and versus the figures we have. The second line PFS was 14 months. Bone only versus visceral were almost same, 14 to 13 months. Safety profile, as expected, neutropenia in 75% patients, thrombocytopenia around 20%, anemia in 18%. So to conclude, this resulted in similar efficacy and safety in Indian patients as we see that of patients on Paloma trials. Next. This is another data from Chennai, palbociclib plus AI. So patient, this was a retrospectively analysis of untreated patients with HR positive, HER2 negative advanced breast cancers who received CDK4/6 and letrozole at Chennai from October 17 to January 19th. Patient who had progression while on hormone therapy and those with palbociclib as second line therapy were excluded from this. So this is a pure first line data. Median follow-up of was 13 months, PFS of 18 months, OS not reached 1 year, PFS of 73 and 1 year OS of 89. Next percent. Next slide, please. So this is another data from Jaipur. 67 patients were commenced on treatment with palbociclib from November 16 to May 20. The total of 51 of these patients were postmenopausal, 16 were young patients of premenopausal. Bone mets were seen in 25% of the patients, visceral alone in 45 patients, and the remaining were having combination of this. Palbociclib was started on first line in 36% cases, 31% had second line, and third line and beyond also were treated with this CDK4/6 inhibitors. Next. You can make out the PFS, median PFS of 18.7 months in first line, 13.8 months in second line and later. The OS in first line was 23.2 months versus 16.3 in the second lines and later. So it is a useful addition in the management of HR positive, HER2 negative advanced breast cancers. Its benefit is confirmed in a real world setting also. And we have seen the real world data from US and the real world data in India also. And we know that this molecule with combination with AI is a good option for HR positive, HER2 negative advanced metastatic breast cancer. Next. Next. So the take home messages, I think there is also a data of around 100 patients. If Pfizer people can chip in, they had to submit data of 100 patients to DCGI for this. I know that because I was a part of that study, and so the data also can be compiled in this. So the real world data of patients on palbociclib. So the take home messages in patients with metastatic breast cancers, available evidence does not support loco-regional treatment. Obviously, for an advanced metastatic breast cancer, you need to give a systemic treatment. The decision should be individualized based on patient and tumor characteristics, site and the number of metastases, and respond to systemic therapy. Endocrine therapy rather than chemotherapy is preferred in patients with HR positive metastatic breast cancer. Chemotherapy may be offered for those who are highly symptomatic and visceral crisis needing rapid response. A combination of AI and palbociclib should be the preferred first-line hormone therapy in HR-positive metastatic breast cancers. Premenopausal women need to undergo ovarian ablation before starting on AI with palbociclib. If the treatment with palbociclib is not feasible, AI should be offered. In patients with bone-only disease, fulvestrant may be offered over AI. At present, ESR1 testing is not recommended. A combination of fulvestrant plus palbociclib should be offered to patients who have progressed on AI. Exemestane and everolimus is also another option next. This is another single center real world experience of 102 patients treated with palbociclib and letrozole. 100 were included for analysis. I think this is from Delhi. 2 lost to follow-up. Objective response rate of 17% and 54%. Adverse events were around 40%. As expected, most reported AE were neutropenia, reported in 13 patients, followed by chest pain and breathlessness. In this patient study, palbociclib and letrozole reported good clinical response at the end of the treatment duration with the manageable tolerability profile in the Indian population. This is another real world data to show that this is quite a tolerable drug and with a good efficacy and safety, with a good quality of life. Next. So to summarize, just 1 minute short, all of the CDK4/6 pivotal trials were designed to demonstrate the benefit of the primary endpoint of PFS. PFS is the accepted primary endpoint in metastatic breast cancer by regulatory authorities. I think we did discuss on this particular topic. Increasing evidence is available from randomized control trial demonstrating longer overall survival with CDK4/6 plus endocrine therapy versus endocrine therapy alone in HR positive, HER2 negative advanced breast cancers. However, the difference of OS was not statistically significant. We did discuss why it was not statistically significant. And if in the subgroup analysis, we did see that the patients with more than 12 months of DFI did show a better overall survival. Real world experience was associated with OS benefit for patients treated with palbociclib. Combination therapy in the first line can help inform treatment decisions in clinical practice. According to worldwide guidelines, CDK4/6 inhibitors in combination with ET are the standard of care for patients with HR positive, HER2 negative advanced metastatic breast cancers. Next slide. So I think with that, we have discussed most of the points pertaining to the use of palbociclib as a CDK4/6 inhibitors. However, if any of my panelists, Dr. Reshma, Dr. Amol, Dr. Vijay, and Dr. Shaunak would like to bring some points in clinical practice or some points to the notice, please go ahead. Yes, Shaunak.
So I think it was a very well conducted session. We got to learn a lot from this. And all the three CDK4s are interchangeable. But with regards to some subgroups, I had a recent case. She presented with multiple bony lytic lesions, and there was no breast mass actually. So she had come to me with an initial impression that it was myeloma. But after the bone marrow biopsy showed IHC positivity for GATA3, GCDFP, and ER, and HER2 was negative. So she had bone marrow metastasis. There was still no primary even after an MRI of the breast. But because she was also in pancytopenia, I'd started her on abemaciclib because I couldn't give ribo or palbo considering its risk of neutropenia. And so she's done well. So I think that is one subgroup. It's a rare case, but I think that's a subgroup where I would prefer abema over the other two due to the difference in the side effects of neutropenia.
That's an interesting case actually. We have seen many such specifically pertaining to prostate, but coming this as a breast was really good to discuss that. Reshma, anything from your side?
Yeah, so very nice to have this discussion with you all. And what I've been observing is that with the CDK4 that we are using, we are getting very nice PFS. So 1 or 2 of my patients have been on palbociclib for more than 2 years, and then sometimes we wonder how, like, we are continuing them, but it is good to see people like the hormone positive subset, metastatic subset, doing so well with such good survivals coming in for these patients.
Correct. So, like I did mention as a passing comment that the CDK4/6 and AI is already there, but CDK with oral SERDs are also coming up in the next, maybe the next generation could be instead of AI having an oral SERD. There's a trial ongoing. Which is comparing AI plus palbociclib, and just to point out, that I don't know how many of the other trials are going on with CDK4/6 and combining oral SERDs, but I see the trials using more of palbociclib as a companion. I don't know why. Maybe it's a better drug, or it's just a comment. I mean, I don't know, but most of the studies are comparing using palbociclib as a CDK4/6.
So I think there is a reason cardiac arrhythmias are more with this combination, SERDs and CDK4. So there is a more risk towards the cardiac issues.
Absolutely, that could be one of the important reason, because even oral SERDs we are expecting cardiac problems. So maybe ribociclib is out in that situation. That is right. Dr. Amol, your comment, passing comment.
It's a nice discussion, sir. I think patient characteristics are more important to individualize the CDK4/6 combination with endocrine therapy. And as per category 1 indication in MBC hormone positive patients, we are now with this all trial data, we are confident to use at a first line CDK4/6 with endocrine therapy.
That's very well said. Dr. Vijay?
So nice discussion we had today. See, I have a lot of patients on palbociclib, and some of them are crossing more than 3 to 4 years. And so that means we are getting good response actually. And according to the data, real world and according to trials, so some of the patients we are getting better results. So you must be having a lot of patients and a lot of experience with these molecules. So you also should share some experience about the palbociclib to us.
So I think most of the points whatever I had my experience already we have discussed on the way through this lecture. But I think yeah, this is a good molecule, and I also said that even 125 is quite well tolerated. What is important, I feel, is when you say that the patient is having neutropenia and you need to step down, I would advise everybody to look at the chart of dose adjustment very, very carefully. If you follow that, not many of our patients will need to be undergo a dose reduction. Why I'm telling is because I am following it because I'm doing a trial, so I need to refer to that each and every word of what is given for dose reduction. Whether you can whether you can call again patient after 7 days, monitor the CBC, how to do a dose adjustment. If you really follow the protocol, I think maybe many of our patients may not require a dose reduction. So that is what I would like to just give my comment as an advice, or maybe just when you see the patient, it's better to have that, because invariably it happens. If you have a WBC of 2000 and you have we have a neutrophil of 700 and 750, we feel that go for a dose reduction. But the protocol does mention that you can wait, you can call after 7 days, see what is happening, and then decide, take a call. So this is something which I think we should follow. And with that, I think we have I thank all my panelists for a wonderful interaction. It was good to interact with you all and learn so many things, and what we really see in our practice as compared to what the real world really sees. With that, I thank Pfizer also and hand over it to Pfizer back.
Good evening all.
I'm Nilesh here. I wanted to thank you, all of you, because initially it was a delay of the session, but the way the session has progressed, it has done a wonderful discussion. So I wanted to thank moderator Dr. Shailesh Bunrade sir and all the panelists, Dr. Amol Kotalwal sir, Dr. Reshma Puranik ma'am, Dr. Shonak Palme sir, and Dr. Vijay Sharnagar sir for the wonderful discussion. Each and every point has discussed in elaborated way. So thank you so much for all the support, sir.
Thank you.
Thank you
And
for
with this, we
inviting us.
can
Thank you.
log out. But thank you so much for the elaborated discussion and wonderful session, sir. Thank you so much.
Thank you so much. Thank you so much. Have a good evening. Bye bye.
Bye.
Thank you, Shailesh sir.
Thank you, everyone.
Thank you. Thank you so much. Thank you.
Bye.